The following presentation occurred during the 2022 South-Southwest Mental Health Technology Transfer Center, MHTTC, First Episode Psychosis, FEP, Conference. This conference occurred from June 1st to June 3rd, 2022 in a hybrid format, with approximately 150 in-person participants in Austin, Texas, and 300 virtual participants from around the world. Conference attendees shared a range of identities and positionalities, including those with lived experience, family members, providers, and researchers. The 2022 theme of innovation and sustainability highlighted not only the radical advancement within early psychosis programs over the past decade, but also the continued transformation that we hope to see of mental health structures and research serving youth and young adults living with psychosis. This conference was an opportunity to engage in shared dialogue across difference, struggle with new ideas, and re-envision a future for mental health structures for youth and young adults living with psychosis. This conference was coordinated and hosted by the South-Southwest Mental Health Technology Transfer Center, MHTTC, in Region 6. An initiative funded by the Substance Abuse and Mental Health Services Administration to provide free training and ongoing consultation to all professionals that serve individuals with mental health needs. Region 6 includes the states of Texas, Oklahoma, New Mexico, Arkansas, Louisiana, and our tribal communities. The South-Southwest MHTTC is a project of the Texas Institute for Excellence in Mental Health, which is housed at the Steve Hicks School of Social Work at the University of Texas at Austin. By way of a disclaimer, this conference was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed throughout the conference are the views of our speakers and do not reflect the official position of the Department of Health and Human Services or SAMHSA.
All right, now we're ready to get started. This is exciting. All right, I am very happy and pleased to introduce our first panel. So our first panel members, if you want to start making your way to the front of the podium here, it would be great. We are going to be having, I guess, a great group. This particular panel is going to explore strategies for effective multidisciplinary collaboration that centers our peer and family support roles. Growing research and lived experience highlights the integral nature of peer and family support roles within FEP programs. Conference attendees, we will have the opportunity to learn directly from FEP providers and their roles on the FEP team. So I'm honored to introduce Hiram Cortes, Angie Tyler, and Clayton Carrier, and they're all from the integral-based RAISE team here in Austin, Texas. Hiram Cortes is the current program manager and has been training in CBT, CBTP, and CPT, trainings that help inform services for RAISE clients. Part of his expertise is collaborating with multidisciplinary teams, including peers and family partner, to deliver comprehensive and person-centered care to our population. Angie is the current certified bilingual family partner and has been with the team for 5 years and 7 months. She is able to share her lived experience with families and help them navigate through community resources. Her work background includes working with Travis County Juvenile Probation, caseworker at LifeWorks for homeless foster youth, and ARC of the Capital Area, working with IDD services, as well as with the Juvenile Justice Program. Clayton Carrier is the peer support specialist who works with young people in a first episode psychosis program in Austin. We are also very honored to have Dr. Molly Lopez as a moderator for this panel. Dr. Lopez is the director of the Texas Institute for Excellence in Mental Health. She is a licensed clinical psychologist and a research associate professor at the University of Texas at Austin. Her research interest includes child and adolescent services systems, implementation of evidence-based practices, and mental health systems development and policy. She's led a number of initiatives that are focused on enhancing the effectiveness of systems that interact with children, youth, and adults with significant mental health challenges and their families. Dr. Lopez currently serves as the director of our South-Southwest MHTTC Center and is our principal investigator for early psychosis intervention network in Texas. We welcome Dr. Lopez, Hiram Cortes, Angie Tyler, and Clayton Carrier for an excellent panel. And with that, we'll go ahead and turn it over to you all.
All right. Thank you so much, Jen. I am so excited to be here with you all today and just have a little conversation about what you all do. And I know we're just having a conversation amongst a few of our friends, right? So Hiram, maybe would you start us out with a little bit of information about yourself and about the team that you work with?
Right. So good morning to everybody. This is a fantastic experience. I was telling some of the staff that after a year or so of doing everything virtual and seeing people by screens, it's really good to finally get in person and get some of that person-to-person connection. So thank you all for coming. My name, Hiram, in Spanish, Hiram. So some people know me by Hiram or Hiram. I currently work as the program manager with the RAISE team here in Integral Care, Travis County. I get the privilege of working with a very diverse group of clinicians, family partner, peers, and my background is in LPC. I started off in Houston, where I started doing my agency my agency work, and I focused quite a bit on trauma and working with predominantly Hispanic, Spanish-speaking clients who were underserved and needed the services in Houston. I made my transition out here to Austin, and I've been working with the RAISE program for about 4 months now, something around that timeline. We work with individuals 15 to 30. They can be in our program for 3 years. They don't have to have schizophrenia diagnoses or schizoaffective. They can have MDD with psychoses or other diagnoses that have psychoses attached to it, so that we can really serve those in need that don't really have any other avenue. We're lucky to have the clinical high risk program attached to it. So we get really, really good clinicians that do a lot of consultation work. They do a lot of screening for diagnoses. We're really, really focused on that. And I'm proud to work with such a tremendous team. They put their heart and effort into this every day. And as I'm sure all of you do, because otherwise you wouldn't be here, right? So it's really great to see you all here, and I'm just happy to work with this amazing team here locally.
All right, thank you. And now we get to introduce some more of your amazing team, right? So Clayton and Angie, if you don't mind, tell us a little bit about yourself as well, your role on the team, and tell us a little bit about what peer support and family peer support looks like.
Good morning, everyone. My name is Angie Tyler. I have been with the RAISE team for 5 years and 7 months, and it's been an amazing journey. My role mainly focuses on assisting the families in providing support for them. And it honestly varies from family to family. My support can be, when they first come in, they're in crisis mode, and it's a lot of listening until we finally get to a point where we say, okay, so what are we going to do? And so we figure out ways to, there's immediate needs. We will discuss immediate needs and identify them. Connecting them with community resources. And like I said, it varies from family to family. I am bilingual, so I also work with a lot of Hispanic families, and it's easier to connect with my families when I'm speaking with them in their language as well. I also provide support with attending some doctor's appointments with them, because sometimes, the family voice is very important. And so what that looks like, their loved one can have a doctor's appointment and the family member has some questions. And so I help navigate that appointment with them and support them through it. And if they have questions, that they feel empowered to ask those questions as well. And so I'm incredibly grateful and honored to be working with such an amazing team. And it's just, it's what drives me every day.
Hi, I'm Clayton. I've been on the RAISE team as a peer for about 1.5 years. I wanted to be a peer because, well, I thought it would be a really interesting job that kind of fit with my personal experience, and I wanted to help people, you know, that had also struggled with mental health problems. I would say that the core of being a peer is sharing this lived experience with other people in a way that is useful to them, that helps them in their recovery. So kind of my main things that I do on the team are checking in with clients and getting updates on how they're doing, sharing this info with the team, helping them get connected to resources that they need. Lots of the meetings with clients, we would kind of do fun activities like playing sports, like basketball, tennis. We'd play Uno card game. We'd play checkers and chess during our meetings. And yeah, that's most of it. So.
That is amazing. I love hearing about some of the unique ways you interact with both families and then with individuals in care. Can you paint a little picture for us, like of some examples of interactions that you feel like went really well, kind of how you've spent some time with those? Maybe Clayton, if you want to start.
Yeah. So for me, a lot of the best experiences with clients were when I felt like my lived experience was really relevant to kind of what they were going through. So kind of, three things that I think have been really helpful for people. I helped one client who hadn't told his immediate family about his mental health diagnosis. And also his friends didn't know, and he was experiencing some paranoia. I helped him think about the importance of a support system. And I kind of shared about how my support system has helped me throughout my recovery and what that has meant to me, and how that's kind of been at times like a lifeline. Made a huge difference for me. We've had a lot of clients recently who are not wanting to take their medication. And so I've talked with a lot of clients about how, for me, taking medication has been just crucial for my recovery from my mental illness. And so I've kind of talked to them about what it looked like in my life at times when I didn't take my medication and how that went for me. Another thing is, and this has come up with multiple clients, is really coming to grips with like, what does it mean to have a mental illness, especially like a severe mental illness, and how that will affect their lives, you know, forever. And what does it mean just to have to deal with that? Some clients don't really have that understanding. They kind of don't really think about it that much, or kind of downplay its significance. But I think talking with someone else that has, I was diagnosed 11 years ago, so I have significant kind of lived experience with my own diagnosis. And so I think that sharing how that has helped me to, live in recovery, I think it's really important. And so I've helped them to think through that and what it means for them.
And, talking about, like Clayton mentioned, having these conversations, not just with the individual, but also with the families. I have learned over the years that, when we're working with families, they're very focused on their loved one's diagnosis. And, they go through phases. It's almost like, they're going through a loss, and it is, they are mourning a loss of the person that they knew. And so oftentimes we have families that don't know how to be around their loved one. Sometimes there's families that, they don't know how to talk to them. The relationship gets strained. And so one of my main goals when working with the families is just normalizing everything for them and helping them understand that their loved one is still alive. And there's ways to bridge that relationship, bridge that gap. And one of the unique ways in which we like to do this is we do activities together, sometimes, like Clayton said, tennis. And that's a great example, because when working with someone and we figure out what they like to do. And so we go out there, we roll up our sleeves. I'm like, okay, let's do this. And so we get very competitive. And so I will get mom out there and the individual out there, our client, and Clayton is right there with him. And so we're playing tennis. And so it reminds the families on how to continue to be with their loved one on a very playful way. And so we start working towards that goal, and just kind of rebuilding that relationship. The other thing that this is probably my favorite, I ask them when they're so focused about, my son this or my daughter that, I'm thinking, you're so focused on your loved one right now that you forgot about yourself. What did you used to do before this? And all of a sudden I get this look, and then I get, no one's ever asked me that. And so once we start talking about it, there's tears, there's a lot of emotion. And then we get to, this is what my hobby was before. And then we go into, let's explore that. When was the last time you did this? So now you're taking the attention away from what, their attention on their loved one's diagnosis and all of things that are going wrong to, how about let's start focusing on you and what you want to do and what your goals are for right now, just to kind of give them a break.
I love that. I love how, you really both talked about finding those things that bring people joy and helping them not forget to bring those into their life, even during stressful times, to keep those going. I love that. I'm wondering, it's so clear, all of the experience and wealth of knowledge that you're bringing to this role. Tell us a little bit about kind of how you got training, what that looked like, and how you think that peers should kind of get the skills that they need to do this work.
I think that when I first went through the certified family partner training, it was just kind of abstract. And it wasn't until I connected my lived experience with the training. And that's when the real work began, not just for myself, but what I wanted to see with other families. I reminded myself that I did not have a family partner for myself. And then I thought about the family partner that I needed. And that is what I wanted to become for these families. And then our agency, Integral Care, would send us to all of these amazing trainings as well. My favorite is Hearing Voices, because it was then that I really understood what our clients were going through as well, not just, you know, my son, but what other families, loved ones were going through. And so I kind of got a broader perspective. So any trainings having to do with, you know, the people that we work with, I find invaluable.
Yeah, so for me, I did a certification process, and the things that were most helpful from it were kind of learning the most effective ways to share my personal experience. There was some training on listening and holding space with clients. That was helpful. I think in an integral care specific training, we learned about kind of what the peer support role is and what it isn't. They were very clear that peers are not mini clinicians. So there is kind of like overlapping subject matter, overlapping interests, I would say, with the clinicians, but we approach it in our own way as peers. It's different than them. That was useful for me. I liked learning that peer support is evidence-based at the beginning of my time as a peer. And also when I started, there was a person on our team who the skills trainer, and she had been the peer previously. So I got to talk to her, and she got to kind of tell me about her experience in the role and what she did. And that was really helpful as well.
Thank you. You know, as we think about kind of supporting our peers on the team, Hiram, can you tell us a little bit, like as the team lead, how you support Angie and Clayton?
Sure, yeah. So as they were both mentioning, they have very, very specific, unique roles within the team. From my background, being a therapist and clinician focused, when I first came onto the team, it took me some adjustment to, we have clinicians on the team, but we also have a family partner and a peer. So how do we, two peers, how do we get that, or how would I understand their role, especially for supervision, for team meetings? How do I include them in that conversation in a manner, not just me, Julie, our practice manager as well, but how do we include them in that conversation in a way where they feel, because they do have an equal voice in what's going on with treatment. I've seen some team meetings where, not in ours, but I've seen some team meetings where it's very, very physician focused, where it is very, very heavy, and the last word belongs to the physician, and what the physician says is what's going to happen. And so we take an approach where the physician has a very important role, but so does everybody else, including the family peer and the family partner and the peer. And so what we do is we're very, very intentional is depending on the type of meeting, is giving them a space to add whatever they have to bring to the table. There's been situations where as a team, the clinical team, we think we're done with the case, or we staff a case and we think we got the main points of the case. And some occasions, Angie or Clayton or our other peer, Yumi, would interject and say, wait, hold on. This is what I have to offer. This is what I heard from the client or the family, which doesn't necessarily coincide with the conversation we just had. And if we don't have that opportunity for them to share that, we miss something super, super important. Without going into many details, it's happened several times where as a team, we think we know what trajectory the client's going on or the family. And because of the information they bring to the table, we got to kind of troubleshoot and try to figure out where we're going because we were missing that info. So Angie and Clayton, they have this very, very unique way of connecting with the clients because of their roles, right? They're not coming at it from a clinical perspective per se. So they have a way of connecting with our clients, especially our population, that sometimes as clinicians, we're going to miss something. And they're like a safety net, if you will, for some of that information that we just may not think to ask or we're just not looking for. So we're very, very intentional in including them in every team meeting, supervisions, as well as group supervisions specific for peers and family partners. So that's kind of how we've structured that to include them just as much as anybody else on the team.
right, thank you. Let's dig in and explore a little bit about kind of the work that you do at different stages in treatment, if that's okay. So I'll let you decide who wants to start, but how about you tell us a little bit about how you take part within your program and sort of the initial engagement of young people and their families.
Yeah, so for engagements, we do the engagements. It's the peers and the family partner that do it. So it just, yeah, I think it's easier for us to kind of come alongside them that way. And yeah, we usually do it in teams, in pairs. So.
And to elaborate a little bit more, when we do engagements, like Clayton said, he and I, the family partner and the peers will go and knock on that door. And the reason for that is because when we knock on that door, whether it's the individual who we are engaging with or the family, we are the first face that they see. So we become the face of the program. And what's really important about that is that when we say we understand what you're going through, we mean it. Because of our lived experience, it's so much easier for us to connect with the family or with the client rather than having a clinician go and say, hey, here's our services. But if it's a parent to parent, when they ask us, have you ever been through something like this? I can safely say, well, my experience is a little different, but I can tell you that I've been there and I'm still going through it. And it's a very long journey. And so I want to help those families navigate through their own journey so that they can find their own voice, so that they can be able to tell their story, not their loved one stories, which is very different, but their own story. The way that works in the team, like Hiram mentioned, I always tell the families this is really important. They are the eyes and the ears. We don't live with their loved one, they do. So they bring a whole different perspective. And so if our clinician or our peer is meeting with a client, how was your weekend? Oh, it was great. It's valid. Mm-hmm. However, when I check in with the family, how did the weekend go? Well, let me tell you, how much time do you have? And then I get, he took my keys, he broke the windows, she punched the wall. Mm-hmm. I get a whole different perspective. So when we come in, we do team staffings. Mm-hmm. And so we're able to bring our own information to the table, which is sometimes it's very different. It's different perspectives. They're both valid, but we understand that when we bring this information to the table, it's very important that we look at, this person's case from all different angles, not just one.
Yeah, one thing about that is there are multiple times where I've met with a client and they say that they're doing great, everything's going really well. I report that to the team, and then Angie says that the parent said like the opposite, like things aren't really going that well. So it's really good to have different angles, as Angie said.
And also, the most important piece about all of this as well is that to be able to ask the family, sometimes they have a lot of information about what's going on and, their different behaviors and what they did, what they didn't do, did they eat, did they not eat? And so I always ask this, is this something that you want me to talk to the team about? Because it's all about confidentiality too. And so, of course, they'll say yes, or, I just don't want them to know that I'm the one that told you. So, confidentiality is key, especially when we're staffing. But we have, we share a whole lot of information with the team. And like I said, it's invaluable information. And that helps us as a team be more cohesive and know how to, better support the families, because at the end of the day, it's we're client centered. And so we always want to go into this, not just like, well, I'm backing the family up or you're backing the client. No, we're person centered. And so we have to always remember, how to go in there and navigate, our supports too.
I think another piece from my perspective in the engagement process is because of the caseload, it's a shared caseload. So we have like an interest list or wait list, if you will. And some of those engagements, once it gets to engagement time, they've been waiting for maybe 2 months, maybe 3 months for services. And so they might not necessarily be in the loop as to who we are, what we do, why we're there, why we're knocking at the door. A lot of these families also, because it is a first episode, they've never navigated managed care before. So it's their first time, it's their introduction, and it's with a pretty heavy crisis. They don't know how to deal with that. They don't know how to talk with physicians. They just don't know the process. And so we're very intentional with having the family partner and peer or peers join up to do those engagements, because the thinking behind that is, if this family has been so heavily confronted with managed care, they might be tired of that. They might just be super tired of that, weary of just trying to navigate that. And if we have a different approach or somebody else who understands that process, who has lived experience, and just comes at a different angle than maybe a clinician would, we get really, really good results with that engagement process because of that. Sometimes our clinicians do go out and do the engagements as well, but we really, really focus on the purpose of having the family partner or a peer join in on those conversations, just because they do have a very different angle of having that conversation with them. And it's not heavy on the clinical aspects of it, because we're not there yet. We're going to get to intake later on. We just want to make sure we have a good first encounter or connection with the families, with our clients.
So you're not coming with packets of paper to that very first meeting? Fill this out for me.
No, absolutely not, because we know that it's very, sometimes we're walking into situations where mental health is very stigmatized, especially in different cultures. And, we can be meeting outside and all of a sudden we're talking in a very low voice. Why are we whispering? Because the neighbors. And so, we have to find a way for, families to feel comfortable in talking about what's really going on. We have families that say, hey, not in our family. Nope. Maybe in my husband's or my ex-husband's family. And then you check in and they both point the finger at each other. But, it's just one of those situations where we have to get a feel for these things and honor that what they're feeling at the moment, and making sure that because it's a very vulnerable feeling to be able to share, here's what's going on, and be open about it. And sometimes it takes time. Sometimes they're not going to trust you. It's going to take time, but we also have to show them, why we're doing what we're doing. And at the end of the day, it's about making them feel comfortable and having them share just a little bit into why we're knocking at their door. And it's all about, we're here to support. We're here to support you.
Can you tell us a little bit about what your roles look like during the goal discovery kind of time period? What does it look like to kind of work with families and with young people to identify their goals?
Well, they usually identify their goals at the beginning with the clinicians, I think when they do treatment plans. And for me as a peer, main thing I would do is really just talk to them about their goals and check in and see kind of what they're doing to reach them, what the progress is, what's holding them back, and just talk about their lives and what's going on.
And when I ask the family, what are your goals? At this moment, they'll say, well, my goal is for my son or daughter to get a job. I said, no. Well, I asked you about what your goals are. Just totally different. And so this is where the work begins. Once again, because no one's ever asked them that for a long, long time, because they've been so focused on their loved one. And so it takes a while, and it takes a lot of redirection sometimes, and patience. And so even if they cannot think of anything, I leave them a little bit of homework. Okay, the next time we meet, we're going to talk about, what did you used to do before all of this? What do you like to do? I've had parents say, well, I used to go to Zumba class. Okay, what's stopping you from going? And then the silence, and then the tears. And so there was a family that I worked with, that we worked with. Yes, a little bit, right? Yes. I think he's reading my mind,
Yeah,
or
I'm not a
something.
mind reader.
She told me, it's been 15 years since I've sewn anything. I said, really? Wouldn't it be nice if you started that again? And she looked at me like, what are you talking about? What? And I said, wouldn't it be nice if you started to sew again? And so we made that her goal. And later on, we'll talk more about the story. This is really close to my heart. So I help families navigate through their goals by focusing on their strengths, what they're really good at, and kind of identifying the things that they want to work on that are not so good. And that can even include the way they talk to their loved one. Sometimes because their relationship is severed, they use certain language with them. And so we hear about it in staffing when the mom is saying, oh, well, he's just crazy. And that hurts. And so I have to find a way to come in and have those conversations with the family, and how to communicate without using these words. And sometimes, like I said, it's tricky and it takes time, but we're in it for the long haul. We can, like Hiram said, we work with families and clients for up to 3 years, and I'm thinking it's a start.
I think some of it, if I can add this, is again, part of the engagement process. We start with the family partner, the peer included in that process. And so if let's say they do meet with the client, the family and the client, they agree to services, then the family partner or the peer would send a quick small blurb to the team. Hey, this person is ready for engagement. The family's on board. This is kind of what the background is. This is what they're interested in. And so then that gives our primary clinician who's going to do the intake an idea of what their goals are, and then they can have that conversation again. And then again, tying it to how we first started is the information that our peer and family partner bring back as we provide services through staffings and all that. As a team, as a clinical team, we might think we have a solid goal as to services, but then some of that information that they bring back saying, hey, no, actually the family's trying to focus on this, or the peer tells us, hey, they really want to focus on this. They just don't know how to share that with the team, right? Then we can have that conversation. And really, again, it's person-centered. It's understanding their perspective, their goals, what they want to do. And again, sometimes we just miss that because we're so focused on the clinical perspectives that the family partner and the peer just have that. Again, they have that angle where they might catch some of that stuff that we might miss on our end.
You started talking about this a little bit, but can you tell us some more about how the two of you work to develop those supports within people's lives over time?
I think when we first meet with the families, you know, that's probably one of the most difficult conversations that we have, because, you know, when we ask, you know, where are your supports, you know, they'll share, I don't have any. Well, why? They've been severed. Their support systems have been severed because of, you know, what's going on in the family. And so we talk about ways and how to rebuild those relationships. You know, if you can imagine a situation where your family's going through so much and you start calling up your friends and or your family members, and you start talking about what's going on with you, and you do it so much that the person on the other end doesn't want to pick up the phone anymore, because they already know that when you call, you know, it's all about what's going on in your family. And you know, well, why don't you just kick them out? Why don't you just kick her out? And it's not that easy. They don't, you know, people don't seem to understand what it is that the family is going through at that particular moment. And then it gets to the point where they just don't want to talk to anybody anymore, because it's always the same thing. And so the isolation starts. The family starts feeling like they're the only ones going through this situation. And it's such a difficult cycle, because it's been going on for such a long time. And so when we go in there, we identify, you know, whatever natural support systems they may have, and even resources out in the community. We refer them to NAMI, to support groups. And these are things that, you know, they didn't even know existed. And so helping them navigate through other support systems so that they can be able to, you know, receive the support that they need when we're not there. So again, you know, helping navigate their own support systems is key.
I think some clients don't want to, you know, feel weak or seem like appear weak to people that are in their lives. So they don't really want to always acknowledge their mental illness and kind of what the impact that has. So that's something that we talk about. With some clients, I want them to kind of see that, you know, they have a vulnerability, and the smart thing to do is to understand it and acknowledge it and work at it.
Thank you all. Okay, how about tell us a little bit about how your role looks as we approach the end of their time in the program. How, you know, what is it that you do to help support their transition to the next phase of their recovery?
We start talking about that transformation or graduating from the program 6 months before. So, so because they're with us for 3 years, it's a long time, and it's easy to just kind of lose track for the families, especially. And then you bring up the conversation, okay, 6 months from now will be 3 years. And of course, we get a myriad of responses. We're like, really? Yes. And it's, you know, it's a very crucial time for us, because now let's prepare the transition and what that's going to look like for not just the client, but for the families as well, because all of a sudden, you know, we became one of their natural support systems, right? And so what can we do to help ease into that other stage? So we come in with community resources, like as I mentioned, NAMI is really good, and other places that they feel comfortable in going. You know, a lot of our families like, well, I know that there's a support group at church. Let's go ahead and connect you. And it can vary from time to time. It can also be pantries, you know, a list of pantries, a list of places that can navigate them through, like paying bills, anything that we identified as an immediate need when we first started. And just, it's kind of like having a phone directory where you have everybody's numbers. Or a manual, what to do if. We make sure that they always have the crisis helpline in case anything happens, that sort of thing. So it just varies from family to family for us. And then we explore the other conversation as time nears towards the end. I remind them of when they first started the program to where they are now. And then I have them identify what went well and what they're still working on and what they can do to continue to work on those things. And then towards the end, we do what we call a warm handoff, because we know that they have to, you know, call and make an appointment to a doctor's office. It's not just like, well, here's the number. I can sit there and help them make that call, and then I'll offer to go with them, so that they can feel like they're still being supported, even if it's their last day on the program.
Yeah. I liked hearing kind of what they learned and gained in the program. Because like I know everything that we're doing, so I'm curious what they're kind of taking from it. And I like referring people to NAMI peer-to-peer class. I took it before I became a peer on this team, and I co-facilitated it twice. And I just think it's a great resource for people with a mental illness. Yeah, it's just great. So always refer to NAMI peer-to-peer.
I think something else that they do specifically is, so we'll close out a client as they're coming to an end. We'll have a conversation. Hey, it's coming up. This is the changes that you've seen. This is what we've seen. But from the very beginning, we know that we're going to be an intensive team. We're going to be there. We're going to provide services for this long. And we want to do that, but we also don't want to be in your life forever, if that makes sense. We want to see you grow. We want to see you develop. And we talk a lot about trajectories, right? This was your trajectory. If you didn't have services, this is a possible outcome. Hopefully with services, with interactions with our team, you have a new trajectory. And this was all, we helped with that trajectory, we facilitated some of that, but ultimately the work was you and your family, right? So you're taking that with you. And then part of what we do also is we'll get a quick, a small thank you card or congratulations card. We'll have the whole team sign it. We'll give it to them. And then there's also a period of follow-up. Once they're connected to a clinic within the agency or outside provider, we'll follow up with them for some time just to make sure, hey, how's everything going? Were you able to make that appointment? You need help rescheduling that? Is there something that we need to close the loop on? We just want to make sure you're okay before we really let you go, right? And part of that process, again, from the beginning, from engagement, the family partners there, the peers are there. At the very end, they're there. So they feel like it's really been this collaborative effort, that they were never abandoned, that they really had a team that cared for them. And that's a big piece of what they do.
Thank you all. So we also know that sometimes families and young people can disagree about what might be best for that individual. So tell us a little bit about how the two of you all negotiate that.
We play dodgeball. That's not true. I'd like to implement that in the team, though.
I'll take that.
Julie says no. All in favor, raise your hand. I'll let Clayton start.
So questions about what we do when there's a
maybe the
disagreement or different-
individual in care and the family have different ideas about kind of what things should look like.
Okay, yeah, so there's a client recently, there's like that kind of disagreement came out pretty sharply. He felt that actually everyone on the treatment team was kind of taking the perspective of his parents. And he'd also said that about previous like counselors and psychologists he'd met with. But he did tell Angie should just take this one. You're the star of this story.
Oh, that makes me cry. So like Clayton said, you know, he did mention that he just felt like nobody was listening to him. And so, you know, when we go in there, we're a very intensive team and we're ready with ideas and all this passion behind these ideas. And we're there, we're showing up. And then there's this wall where he's just not giving us anything. And I was noticing a lot of that, especially when I was going into the home and meeting with his mom. And I started noticing little things around the house. He likes to crochet. And I noticed these squares under each piece of furniture. And he even made one for the blender. And he made a rug going up the stairs. And he made a chunky blanket. And I'm thinking, and I'm just noticing these things. And so we're going out again. He's not giving us anything. And it's that wall we're hitting. And then he verbalized that. And he said, I just don't feel like anybody is listening. And I thought, but I've been noticing. And so I said, hey, I noticed that, you like to crochet. And I see it. And I'm baffled as to how you did this. Well, he taught himself. And so I thought, what if we just started from ground zero with him? Because no, he does not want to work on getting a job. No, he does not want to work on going back to school. No, he does not want to work on his hygiene. In fact, these are all things that his parents have been telling him that he needed to do. And his goal was, I just want to live as minimally as I can. And then I sat down with him and had the conversation. What does that mean? I want to live in a little home. I don't want to spend any money. Okay, how are you going to sustain yourself? I haven't gotten to that yet. All right, let's explore. I love to garden. I said, have you ever thought about growing your own food? And he looked at me and I said, do you like tomatoes? What if we just started there? And all of a sudden his eyes, like he it was like, whoa, somebody's listening. And so I said, I'll be back next week. And I came in and I had 2 little tomato plants. And all of a sudden there was that conversation about, him liking the way that tomato plants smell and how great it is to eat a fresh tomato. And all of a sudden, this conversation. And I thought, this right here, when we focus on the person's strengths. And of course, I go out to Michael's and I get these giant, and he didn't want to meet with anybody else. in the team. And I'm like, but I'm the family partner. Okay. So then all of a sudden he goes, hey, do you want to go play tennis? I said, I've never played tennis in my life. So I called up my niece. It was like the state champion. Hey, I'm going to need some pointers here because I don't know what I'm going up against. So I incorporated mom in this situation. I said, hey, I'm not very good. And I know you and your mom used to play like years back, but I want you guys to help me, teach me how to do this. And so that became a teaching moment for both of them and myself. And then we decided, let's incorporate the peer. All of a sudden, you know, that's our competitive nature, right? And so we went back and I said, hey, again, he does not want to meet with anybody else. So this is the way we incorporated the clinician. I told our clinician, Sanji, I said, hey, we're going to do a pop-in. And she says, we are? I said, yes, we are. So we just show up to the house. That's what, we're just going to pop in to see him. And so we knock on the door. He was not expecting us. He just had this bewildered look on his face. And we're holding these two giant balls of yarn. And he's looking at us and we're looking at him. And it took him a minute. And I said, help. He goes, well, what you do is you want it. I said, I can't. You're explaining this to me, but you need to show me. And so again, that teaching moment with the clinician, making conversation about something that he loves to do, but shifting gears with him and her asking him questions about, goals in his service plan without him even noticing. And so sometimes thinking outside the box and doing the very things that they like to do is the beginning of, it can be the tiniest thing, but it's the beginning of something huge and something that no one's ever really done. And so that's how we that's how we help our clients just kind of sit back and say, okay, all right, so they are focused on me, not my parents, not it's like any other experience he's had.
I think going back to the question real quick is, as you can tell, there's a lot of passion behind the work for our partner, family partner, and peer. And so that makes it really easy for whenever we have the staffings, and there is a difference in, hey, this is what the client wants, but this is what the families tell me they want. They make my job really easy, where I just facilitate that conversation and we come to terms as to what's best for, long-term, what's going to help out the family and the client. How do we have that conversation with them? And something that also makes it easy is both Clayton, everybody on the team, but since we're highlighting them, Angie and Clayton, they don't take anything personal, right? They focus on, this is about the client, it's client care at the end of the day, what's going to benefit them at the end of the day. And so that just makes my job a lot easier, where if there is something, if there's a conversation we need to have in regards to that, it's very easy to have it. This is what the client needs, or this is what the client wants. This is what family wants. Is there a middle ground? How do we come to that? So they don't take anything personal. They're professional. They focus on what the client needs, what the family needs. And at the end of the day, that's what matters.
So I do have one more question that I'm going to ask each of them, but I also know that you can see the wealth of knowledge that these three folks have. So we want to encourage you, if you have questions, you can certainly come down to the microphone when we get to that point, but also we're going to send Arnold through the crowd to pick up your cards. So I'm going to come kind of cueing you all that if you've got questions you want, we probably won't be able to ask all of them, but please share them. We'll do our very best. Okay. So for my final question, the theme of our conference is about sustainability and transformation, right? How do we do this work even better? So would each of you all share what you think are one or two of the most pressing areas for transforming the work. And if you have any ideas about what that might look like, we'd love to kind of hear that.
I think for me is having more family partners. Family partners are crucial to the treatment. And especially with helping families navigate their own journey and finding their own voice, and them sharing their stories with others and empowering them to do so. I think that there aren't enough family partners. And I think that, you know, if other teams started incorporating, you know, the voice of the family partner and identifying how important it is to the person's treatment, I think that's a good way to start.
Yeah, so before we did this, we got an email with some homework. There was an article on implementation of peer services. I didn't read all of it, but one thing that I did see in it was that it's common for peers to report that they feel undervalued on their teams. And this wasn't my experience at Integral Care, but I think it's something I could speak to. I think it's very important that peers themselves and their whole team understand kind of the limits of what peer support is and is not. And I also think it's very important that everyone understands like really the positive contribution that peers do have and their importance on teams. And kind of starting out as a peer, I thought a lot of that would have to do with talking about experiences and symptoms. And I think that is part of it. But I think another very important part of it is just helping people to understand and come to terms with the fact that they do have a mental illness and that will kind of affect their lives in significant ways. And that it's important to think about how to just live with it and live good lives.
I think from my perspective, I think one of the biggest things is coinciding with what they shared is just letting the community at large know that there are, I don't know if this is the right word, but alternative methods to just like medication or the medication model. So we are lucky to have 2 prescribers that work with us that are very open-minded in terms of if we have a client, medication isn't working, but they're connecting with the team, hey, let's lay off the medication, let's engage them, let's see how that works out. And then we'll have a conversation later on about medication. So just if the community at large knows that there are teams, first episode programs out there that think outside the box, that do whatever we got to do in order to help these individuals out. And a lot of times these are individuals that have no other resource. They're low income, they're already marginalized. That would be fantastic. And I think having events like this just definitely get the word out. We also get to work with some UT Med students that come and shadow some of our staff, and we're very intentional of having them shadow the family partner and the peers as well. So they get an idea of what work they do. They can hopefully then take that back to, you know, their education and hopefully carry that on wherever, you know, their journey takes them. But just getting the word out, knowing, letting the community know, hospitals, resources, anybody, that there are first episode programs that we do have. Again, I don't know if this is the right word, but alternative methods of helping individuals out that maybe are tired of like the medication driven programs that have been in existence for a while.
You all, that was outstanding. Thank you so much. Clayton, Angie, Hiram, you can just feel how passionate you are, how genuine that you care for others. I just want to take a moment to thank you for that great panel. Yes, please. really, really outstanding. And I got to tell you, we've gotten so many questions. I was really touched by that too. Everyone has been putting questions out in the basket. So I know this is our opportunity now to get some feedback from folks. I'm going to ask Arnold and Grace, are you all ready over there? Because we can take a few if you're ready. If not, I can go virtually. Do you have one to start with us? All right. You want to come up to the microphone? Arnold's the best. So
Yeah.
Test. Can you
Here
hear
we
me?
go.
I think
Okay.
there's one in the back too.
All righty
and
then.
we'll
Well,
grab it.
how do you encourage our clients to become peers in an area where peer roles are not in abundance or available?
I'm sorry, can you repeat that?
How do we encourage our clients to become peers in an area where peer roles are not in abundance or available? So how do you
So
recruit
clients
peers?
become peers.
You know, for me, I think that for a family partner, I can only speak for a family partner's perspective. Everybody has a story. Everybody in this room has a story. And while a lot of us aren't parents, maybe some of you are, maybe some of you aren't, you know, we have different walks of life. And so our story is important. And so one of the things that I encourage, you know, the families that I work with is finding their voice and sharing their story, empowering them to share their story with others, and helping, and if they're interested in doing this, helping them navigate through the services like, you know, giving them the information to become a certified family partner. And then seeking those programs that currently exist that help them become, you know, family partners in their organization, but above all, and most importantly, finding their voice and sharing their story is key.
Yeah, I mean, so it was part of the question that they'd be serving in areas where there aren't available peer jobs?
Yeah, so like,
'Cause
I think,
I wouldn't encourage my client to do something where they couldn't get a job. But if they could get a peer job, I would totally encourage them to do it since they do have the lived experience, and if they're living in recovery and they want to help people with similar experiences, I would definitely encourage them to do it.
yeah, I think it really just tells to the recruitment of, you know, getting more peers involved and what better people than folks that have the lived experience, the folks that you are currently serving.
Awesome. Thank you. I'm going to go on to virtual. Hiram, did you want to
Oh, no,
add
just
anything?
that's a
Okay,
really good question. I
very
got
good.
my thoughts going.
Okay. I'm going to ask our virtual folks that are covering, do we have any questions from the Q&A pod that you'd like to share?
Yeah, hi. Sorry, there is a slight echo. I will figure that out after we ask the question. So one person asked, I notice a lot of people have different links of FEP programs. How can someone get their program extended?
Links, different links
terms
of
of the
FEP
link.
programs.
So the question is, if there's different needs for individuals, they go through the program, can they get an extension? Did I understand that?
I think it's that programs are set up with different lengths of time and care.
Okay. Yeah, so our specific program at Integral Care is 3 years. And so it's very intensive. It's very, I mean, they get so many hours of services. And again, the idea is that we are introduced in their trajectory for a limited amount of time. We're intense for that reason, but eventually we don't want to be part of their life at some point, right? Because then that's not empowering them. That's not that's not respecting their autonomy. So the idea is if we're providing good enough services, they should be ready at some point. So our specific program is 3 years. By that time, we feel like most of the clients that have graduated are pretty well off. Again, we have a period after that where we do follow up just to make sure that they did connect with the services that they chose after our program. But we're very specific in that we're going to be part of your life. We're going to be part of your trajectory for some time, but eventually we have to let you go because we respect you enough to know that you're going to be able to do, what you got to do. You're going to be able to take care of business from what you learn from the program. And that's what's built into services. So I don't know if that answered the question per se, but that's our approach to it.
Thank you. Arnold, do you want to go to next question?
Sure. So we have some questions regarding funding. Essentially, we see the importance of these positions. How is it that we can convince or work with systems to further fund your positions, to expand the positions, to increase access for people? And I know that's it's one of those things that if we could all just give y'all,
I think everybody in this room, if we could all agree on one thing, it's funding, right? It's very much needed. So no, I think practical things that can be done from, at least from like my perspective and our practice administrators' perspective, is the more community outreach that we do, the more that we get the name out to the community seeking those services, and just, if they go, let's say we have a client, they've heard of the program, or by some way they've heard of us, what we do, one of their family members or a friend ends up in the hospital during the first episode, they're going to remember our name. They'll let the hospital know, hey, let's try reaching out to this program. The hospital now knows. So it's very interconnected if we get the name out there. So doing networking, conferences like this, also getting, this is something that I hadn't thought about and I learned from Julie, is when we do, or when Julie has done presentations for the agency in terms of funding, she'll get pictures to the names, right? So it's not just the program. There's people behind this program. Who's Angie? There's a picture of Angie. Who's Clayton? There's a picture of Clayton. And so now the people that are seeing the presentation, we're not just talking black and white. We're not just talking about a program. We're not just talking about money. These are people, right? These are faces that are going out there into the community, and ultimately it's giving back to the community. So if we don't want to invest so much money on the other end where people are going into the hospital over and over and over again, let's invest some of that, in some of our programs that can prevent some of that cycle. So just my thought.
And to add to that, and I saw Julie smiling, we did have the opportunity to go and speak to the people at the Capitol and share our clients' stories with their permission, and to talk about how important programs like these are. And so having that opportunity and sharing those stories with them, and just trying our best to get the word out and to share this information with them is also really important. But a lot of outreach, and I did have that opportunity to go and talk to them, and it was a great experience. And I can only hope that that experience continues to go, to be, and they can remember, hey, these are really important programs for our community.
I just have to put in my 2 cents worth that we have such a great, group here. If you think about it, and even broader, we've got to also prove this up, right? We've got to, we've got a lot of evidence behind peer support and family peer support. And let's also kind of show what remarkable differences it makes in our early psychosis care and get that word out too.
Excellent. Thank you. I'm going to move back to Darcy. Darcy, do we have another question from our group?
We do. And sorry again about the echo earlier, y'all. I'm hoping that it is fixed. Someone asked, does your family partner / peer specialist work with both the youth and adults in your program? Or does the family partner primarily focus on working with the youth and their families, and the peer specialist with adults in the program?
I can work with youth and adults, but it's kind of a tricky question for me, because although I cannot, it's all about the codes and the billing and whatnot. And so we try not to focus on that if there is an adult client that cannot connect with anybody in the team just yet. And so if that client is connecting with me at the moment, this is a really good opportunity to start incorporating, other team members gradually. And so with youth, I have been in, doctor's appointments with them and the family, and they seem to connect well with me. And so, we have a good rapport. So in our team, I can work with both, but also making sure that the family is also incorporated during these visits.
And yeah, I'm the peer for everyone in the program. That's like 15 to 30. So
they work across, whether it's under 17 or above. Sometimes, like Angie said, we do have to figure out a way to get creative in terms of codes and billing and some of that, but we don't let that be the barrier to services.
Excellent. Thank you. Arnold, do we have the next question?
So there's a couple of questions really about you all and how is it that we can support you all in your roles so that you don't get burned out, by the subject matter, just by doing your jobs as well as you do.
Part of the thing that I do with families is, talk about self-care. And so as equally important it is for me to self-care, because at the end of the day, I have to go home to my family, right? And so I have found creative ways that, I will cook, I will garden, I tend to leave things at the door. I have like a ritual, my shoes will stay at the door. That for me, that represents everything that happened at work is going to stay outside. And so I'm walking into my home, my space, and making sure that I continue to self-care so that the next day, I can go out and continue to help families that need my help at that particular moment. So finding, just like I focus on what are the family strengths, what are my strengths? And ask myself that question and actually do some of those things that help me, just kind of, take care of myself too.
yeah, I mean, for me, I think it'd be overwhelming if I was the only person doing everything, but we have a great team and everyone's really supportive and there's a lot of humor on the team. I think that helps a lot.
I think from my perspective, what I try to do with the team is during individual supervision. So we'll go through the case and we'll talk about what we have to do. But I'm always intentional of trying to make a space for, hey, how are you doing? Right? Do you have a good work life balance? What are you doing specifically for self-care? So there's always a moment in individual supervisions where I'll touch on that, just to highlight the importance of make sure that you keep up with that, because we are a very specialized team. The population that we serve, there might be crises. You might get hit by 3 crises in one day and it's back to back to back, and that's draining. We're all human, right? And so I'll tell the team as well during supervisions, if you don't take care of you, how are you going to take care of somebody else, right? You got to fill up your emotional bank, your strengths, in order to bring that to the table when you meet with the clients, with the families. And then also when we meet with our entire team for monthly team meetings, we'll do a potluck. We'll have a certain theme to it. This month, I think it's okay if I share, we're going to do guilty pleasures for potluck. So that's going to be an interesting turnout. And so humor is a big part of how we connect with the team and how we keep our spirits up.
It's going to be so unhealthy. I can feel my arteries clogging up already. And we haven't even had the meeting yet.
We're
going to go on a jog after.
No, you're going to go on a walk.
You all, this was outstanding. We've reached the end of our time for questions. Thank you again. Thank you for demonstrating your expertise individually and then your expertise as a team. It's beautiful. And thank you for modeling that for us all. So another round of applause, please.
Thank you for joining us for the recording of this presentation from the 2022 South Southwest Mental Health Technology Transfer Center, MHTTC, First Episode Psychosis, FEP Conference. To learn more about this conference or the work of the South Southwest Mental Health Technology Transfer Center, please see our website, accessible by the QR code on screen. You may also join our newsletter or follow us on Twitter or Facebook with the QR codes on screen now.